Bartter syndrome is a rare congenital disorder associated with salt wasting and diuresis. Now, if it's rare, why am I bringing it up? This is a good case for understanding several functions of the nephron. 1962, it was Frederick Bartter that first described this condition. This list is associated with a Bartter syndrome, a hypokalemia, alkalosis, muscle weakness, etc. And we'll talk about most of these throughout this discussion. To help you understand this syndrome, it might be useful to review the videos on the renin-angiotensin-aldosterone system, on ADH, and on the loop of Henle. Bartter syndrome comes in several types. Type 1, Bartter syndrome, is a defect in the sodium-potassium 2-chloride cotransport mechanism on the thick ascending limb of the loop of Henle. If sodium cannot enter the epithelial cells, then sodium cannot be pumped out into the interstitium. Type 2 is a defect in the potassium channel. So if potassium cannot leak out, potassium will not be involved in this mechanism. Type 3 is a chloride defect. Accumulation of chloride in the cell will inhibit the sodium-potassium 2-chloride cotransporter. Type 2 and Type 3 are not as severe as Type 1, however. There are two others that I wanted to mention just briefly. Type 4 is a variant of Type 3 in which the subunit Barton is defective. And I bring this up because this type of chloride defect occurs in the stria vascularis of the inner ear. And if you want to understand more about that, I have a lecture on sound transduction. The stria vascularis is important in trying to develop a high potassium concentration in the endolymph. A defect in this chloride channel inhibits that function. Type 5 is a calcium sensing receptor, CASR. Normally, hypercalcemia will trigger the inhibition of the sodium-potassium 2-chloride cotransporter. However, in this case, this is a hypersensitive receptor and therefore is inappropriately inhibiting the sodium-potassium 2-chloride cotransporter. Type 5 Bartter syndrome is also associated with hypoparathyroidism because this same calcium-sensing receptor appears on parathyroid glands. And this hypersensitive calcium-sensing receptor is turning off PTH release. In addition, there's some evidence that this calcium receptor contains non-self antigenic properties, leading to the destruction of some tissues. In normal individuals, the transepithelial voltage is positive in the luminal side relative to the serosal side. This helps move cations, especially calcium and magnesium, through the paracellular pathway, eventually into the blood. However, during Bartter syndrome, this transepithelial voltage disappears, making it hard to move cations like calcium and magnesium into the blood, leading to hypercalciuresis and a loss of magnesium as well. The urine concentrating ability is described in the loop of Henle lecture. I'm going to mention only 2 points on that. The first point is that sodium is pumped out of the thick ascending limb into the extratubular space, but water does not follow. The result of this is to dilute the urine moving up the thick ascending limb. But because sodium concentration is building up here, water is free to move out through osmosis. So we see a concentration as we descend until we reach this hairpin. Then we see a dilution. And this sets us up for the ability to reabsorb water in the medullary portion of the collecting duct. I'm using 300 milliosmoles here simply because it's a nice round number. The plasma osmolarity is closer to 285 milliosmoles. In the case of Bartter syndrome, if the sodium-potassium 2-chloride cotransporter is defective, we can't move sodium and chloride out of the tubular fluid. And if we can't move it out, we can't pump sodium into the extratubular space. And if we don't have a concentrated environment outside the nephron, then water will not follow. Osmotically, we will then have a situation in which we can no longer concentrate the urine. Now, in my talk on the renin-angiotensin-aldosterone system, I pointed out that the macula densa is strategically situated between the afferent nephron and arteriole, and it senses sodium chloride delivery to this region and triggers or inhibits the release of renin. We know there's a high sodium delivery to the macula densa because we're not removing it from the fluid in the thick ascending limb. So why are we seeing hyperreninemia in Bartter syndrome? Normally, this high sodium chloride concentration will enter the cell and trigger the release of adenosine, ATP, which will cause vasoconstriction to reduce glomerular filtration rate and inhibit renin release. But we're seeing hyperreninemia, not hypo. So why is the high sodium delivery to the macula densa not causing a decrease in renin secretion? That's because this is the same cotransporter that's defective in type 1 Bartter syndrome. In addition, type 2 and type 3 Bartter syndrome will affect these potassium and chloride channels, reducing the ability to sense sodium delivery. So the macula densa cells are seeing no sodium chloride delivery and therefore triggering high secretion rates of renin. Now let's look at this a little bit more carefully. This is the NKCC2 transport, sodium potassium 2-chloride transporter, type 2. Now the NKCC type 2 transporter is located on the apical membranes in the nephron. NKCC1 transporter is located throughout the body. We see it, for example, on the basal membrane of the pancreas, allows us to secrete sodium and chloride into the pancreatic fluid. That transport mechanism is not affected by a defect in this NKCC2. If we're not bringing in sodium and chloride, then we are not triggering the release of adenosine, and adenosine is a brake on this system, so we've taken our foot off the brake. In addition, low chloride triggers a p38 MAP kinase, which in turn triggers the gene coding for the cyclooxygenase 2. Cyclooxygenase 2, in the presence of prostaglandin synthetase, will trigger the production of prostaglandin E2. Now, prostaglandin E2 stimulates adenylate cyclase, cyclic AMP, pKa, and we get this high secretion rate of renin. If we use an automobile analogy, we've taken our foot off the brake and we've applied pressure to the accelerator, so we get this hyperrenin secretion. Type 1 Bartter syndrome can be simulated by abuse of the diuretic called furosemide. Furosemide blocks the sodium-potassium 2-chloride transport mechanism in the thick ascending limb, producing exactly the same results as type 1 Bartter syndrome. In addition, it's blocking the transport mechanism on the macula densa cells, causing hyperreninemic hyperaldosteronism. So what's causing our potassium loss then? Hyperaldosteronism will trigger, through this mineralocorticoid receptor, the production of and trafficking of epithelial sodium channels to the membrane, and renal automedullary potassium channels as well. So sodium is coming in, kicking potassium out. Because of this mechanism, we tend not to see serious hyponatremia, because we are pulling much more sodium in the cortical collecting duct through this mechanism. Also, the nephron contains these primary cilia. A primary cilium will bend according to flow. We know we have an increase in flow because the individual is experiencing diuresis. That increase in flow triggers the opening of calcium channels, and calcium then stimulates the secretion of potassium. So we're losing potassium here as well. In addition, remember, we are not removing potassium in the thick ascending limb or in the macula densa cells because the sodium-potassium 2-chloride cotransport mechanism is defective in type 1 Bartter syndrome. How does this hypokalemia affect acid-base status? One major mechanism is this hydrogen-potassium exchange mechanism. Under hypokalemia, that is, low potassium concentrations here, we are stimulating the movement of potassium out of the cell, which in turn causes hydrogen ions to move into the cell, leading to alkalosis. Hyperkalemia will have the opposite effects. But that's not the only thing. Alkalosis also affects potassium levels. Under alkalotic conditions, low hydrogen ion concentrations, this exchanger is inhibited. There are fewer hydrogen ions to move in, less potassium will move out. So alkalosis can also produce hypokalemia. The two things work hand in hand. What about the effect on cardiac and skeletal muscles? There's a decrease in potassium conductance due to the downregulation of some potassium channels. So potassium permeability, potassium conductance decreases. That leads to a prolonged ventricular repolarization, and on myocytes, that leads to a broader, flattened T wave. We see this ST depression, there's the T wave. It's been flattened somewhat. Under very extreme conditions of hypokalemia, this continues to get flattened and may even become inverted. And we begin to see the U wave increasing in size and will continue to increase with severe hypokalemia. I'm going to leave this up. I'm not going to read through all of these things. Here we can see what's happening to the resting membrane potential and phase 0 of the ventricular action potentials, and also the effect on the SA node. Simply hit pause if you want to read through these. Muscle weakness was one of the symptoms of Bartter syndrome. Hypokalemia decreases potassium channel conductance. That lengthens the repolarization time. Transmission of action potentials becomes disrupted and signaling is disrupted. All of this leads to a generalized weakness in the muscles, even a paralysis. And cramping may also occur if the muscles are stuck in this depolarized state. This individual would be suffering from diuresis, and that could lead you to other potential diagnoses. Gittleman syndrome, for one, Little syndrome, or diabetes insipidus. It's easy to rule out diabetes mellitus because there's no sugar in the urine. Now, Gittleman syndrome is a defect in the sodium chloride cotransport mechanism in the distal tubule. This will lead to salt wasting. This will have no effect on the concentrating ability of urine. It will also have no effect on the hyperenemic hyperaldosterone that we're seeing. Chlorothiazide, any thiazide diuretic, blocks this channel and can mimic Gittleman syndrome. Little syndrome is a defect that causes the sodium channels to remain on the apical membrane of the cortical portion of the collecting duct. These epithelial sodium channels are causing high sodium entry, therefore potassium exit. Little syndrome would produce hypokalemia, but would have no effect on the concentrating ability of the urine, nor would it produce hyperenemic hyperaldosteronism. The diuretic spironolactone could block this mineralocorticoid receptor, but that would have very little effect on the system because aldosterone is not in high concentration. Therefore, the problem isn't hyperaldosteronism. The problem is the inability of the trafficking system on the epithelial sodium channels. Central diabetes insipidus is inadequate release of ADH. Fewer aquaporins leads to a higher rate of water loss, diuresis. However, it doesn't explain the salt loss. And this would be an easy test to perform. We just inject pitressin, which is vasopressin, and if we see no change in the concentration of the urine, then central diabetes insipidus could be eliminated as a cause. But then what about nephrogenic diabetes insipidus? We could have high levels of ADH, but the cells are not responding to the ADH, nephrogenic diabetes insipidus. And once again, that would not explain the excessive salt wasting. It cannot explain the hyperenemic hyperaldosteronism. So, diabetes insipidus. Central diabetes insipidus can be ruled out, no effect with vasopressin. Through inductive reasoning, we can eliminate nephrogenic diabetes insipidus. One interesting point, however, with nephrogenic diabetes insipidus is that hypokalemia can induce nephrogenic diabetes insipidus by downregulating the aquaporin 2 channels on the apical membrane. Acquired nephrogenic diabetes insipidus is not as severe as congenital nephrogenic diabetes insipidus, and it is reversible. I'm going to leave these last few up here for a few seconds. You can pause and read through this. This gives us an indication of the cascade of events from salt loss to the hypokalemia, metabolic alkalosis, and hyperenemic hyperaldosteronism. I'm just here summarizing the effects of angiotensin II to see how angiotensin II leads to an increase in potassium secretion. This diagram shows the long-term effects of high concentrations of angiotensin II on the cardiovascular system, and I'll let you read through these if you hit pause. So what is the treatment for Bartter syndrome? Potassium supplements clearly need to be included, and liberal salt intake because we're also losing sodium chloride. Aldosterone antagonists and diuretics such as spironolactone will inhibit potassium loss, but it will also inhibit sodium uptake. ACE inhibitors could be used to counteract the effects of angiotensin II. Nonsteroidal anti-inflammatory drugs are used to decrease the prostaglandin synthesis. A COX-2 inhibitor, for example, indomethacin, for example, would block the prostaglandin synthetase activity, reducing prostaglandin synthesis, reducing plasma prostaglandin, and prostaglandin excretion in the urine. Well, that concludes this talk on Bartter syndrome.